Welcome to the official podcast of the Ogden Surgical Medical Society. Since 1945, the Ogden Surgical Medical Society has been educating our medical community. In this podcast, we bring you the voices of medical experts in your community and around the world. Please note that the opinions and ideas shared on this podcast are of the speakers and not of the opinions of the Ogden Surgical Medical Society or its board. All medical topics discussed are not to be taken as strict medical advice, and individual clinical judgment is warranted when applying information to patient care. It is the responsibility of the listener to judge for themselves the applicability of the information discussed in regards to their medical practice.
Welcome back to the Ogden Surgical Medical Society podcast. We are excited to bring today's topic, strategies for management of teenage anxiety, to you, our audience. I'm Kirsten Baca, the Ogden Surgical Medical Society 2024 president. I am a board-certified anesthesiologist and pain medicine specialist, and I practice 100% pain medicine in Clinton, Utah, as a solo practitioner with an awesome physician assistant and team. I am also mother to 5 great kids aged 4 to 16, and today's topic is especially near and dear to my heart. I am joined by my co-host, Dr. Val Johnson. Would you please tell us a little bit about yourself?
Yes, I am old. I am way beyond teen or adolescent years. I'm a retired pathologist and long-term trustee and historian of the Ogden Surgical Medical Society, and have a lot of interest in all of the topics that we present and provide at our meetings and podcasts each year.
Thank you, Dr. Johnson. The Ogden Surgical Medical Society conducts surveys after each annual conference, and a topic that was requested multiple times after our 2023 conference in May was teenage anxiety and strategies for management. Today, we're lucky to have Bryan Bushman, PhD, with us to address this important topic. Bryan Bushman has been a licensed clinical psychologist in the state of Utah since 2008. He is an author, lecturer, and clinician who is passionate about helping others through community outreach, research-based psychotherapy, and neuropsychological assessment. Dr. Bushman received his master's degree and PhD from Utah State University. He completed a pre-doctoral internship in Danville, Pennsylvania, at the Geisinger Medical Center, providing therapy sessions to children and teens with various anxiety disorders. Dr. Bushman then completed his postdoctoral fellowship in Memphis, Tennessee at St. Jude's Children's Research Hospital. He worked as a clinical psychologist and neuropsychologist at the McCady Hospital Behavioral Health Institute in Ogden, Utah from 2008 to 2022. And presently, he works as a clinical psychologist at the Counseling Center in Centerville, Utah. He has received extensive training in the following modalities: acceptance and commitment therapy, dialectical behavioral therapy, cognitive behavioral therapy, internal family systems, family therapy, and eye movement desensitization. Regarding assessment services, he has received specialized training in neuropsychological assessment practices related to autism, developmental learning disabilities, ADHD, and traumatic brain injury. Welcome, Dr. Bushman.
Hey, thank you. Thanks for having me, and thanks for the introduction. It made me seem a lot cooler than I really am.
Well, you have a fantastic background that you bring to the table today. To start, I'd like to first ask you a question that we all get asked pretty frequently in our practices, but how did you become interested in psychology, and in particular, adolescent psychology?
Well, like I was teasing you guys before the interview began, sometimes it's hard for me to remember that just based on the day that I'm having. But I think a lot of it had to do with me being a teen and going through my own period where I felt really detached from others. And the question of, when I went through my own period of detachment, how would others have kind of reached me? How would they have been able to talk to me? Being able to kind of explore and answer that question, I think, has been something that I've always been fascinated by.
I'll have to have you explain a little bit more about detachment or what that means. I'm just a simple pain doctor, but that sounds very pertinent. Dr. Johnson.
How do you tell the difference between normal worry and something that is pathological?
That's a great question. I think that what I like to do is I like to ask teens when I'm talking to them alone 4 questions. The first question is, give me a list of your top 3 worries. I say everybody worries about something sometime. What are your top 3 worries? And so it'd be normal for teens to talk about being humiliated, being alienated, not living up to expectations. That would be pretty normal for most teens. So I have them give me a list of their top 3 worries. And then I ask a follow-up question, which is, do these worries, can you control these worries, or do they control you? I think that's an important follow-up question because we all have worries, but do our worries control us? And if they do control them, I say, give me a percentage. How much of a percentile do they control you? Are we talking about 50% of the time, 60, 70% of the time? And finally, when it does control you, how does it change your behaviors? For instance, do you use drugs? Do you act out sexually? Do you avoid? Do you isolate? Do you procrastinate? Popular top 3. And then once I get a sense of that, then I can ask some following questions about how long this has been an issue for them. And was there anything that happened in their life that kicked off the worry or started the worry up for them? So usually by asking those series of questions, it helps me to understand, first of all, what are the topics that they worry about? And secondly, how much does the worry interfere? Because really that's what we're trying to do when we determine between normal worry and something pathological is the level of interference. How much does it drive what's going on in the adolescent's life? And I think that's a good kind of way to make a determination between those two things.
To follow up on that, then, what are common worries for teenagers, both in their early adolescence and later on when they're older?
Okay, so first let's divide adolescence into 3 buckets. We got early adolescence, which is ages about 11 to 13. We got middle adolescence, which is ages 14 to 16, and late adolescence, which is 17 plus. Now, obviously, there's some differences as far as culture and temperament, but that's a good generalization. Now, when we think about the first bucket, the early adolescence, 11 to 13, the big developmental or worry kind of issues there is obviously puberty and gender related expectations. I have to say, as a side note, that puberty gets a bad rap. I mean, it gets blamed for everything. When I find that actually conforming to societal expectations is kind of a bigger driver, but that's one thing. You also have to adjust to new cognitive capacities. Most early teens believe in the personal fable, it's been called. The personal fable is the idea that I am so unique and what I'm going through is so unique. There's no way that any adult, including my parents, can possibly relate to what I'm going through, right? They also have what has been called the imaginary audience, which means that they always feel like they're on display, which is why these preteens suddenly have this drastic kind of change in personality. And then finally, they're trying to find a place among their peers. You know, kids, when they're in elementary school, they're all interested in the same thing. But in junior high, they always start to diverge as far as their interests. So that's the early adolescent period. Now, middle adolescence is more about handling sexuality. How are they going to define themselves sexually? Which is obviously not something that they usually want to volunteer and talk to their parents about. They're also trying to balance autonomy and accountability. You know, they want freedom without everything that is entailed by that. And they're also trying to make moral decisions. Now, what do I mean by moral decisions? Well, decades ago, there was a researcher by the name of Lawrence Kohlberg who talked about how kids develop. First, they decide what they're going to do to avoid punishment. Second stage is to get rewards. Third stage is to get approval from a peer group. And then fourth and fifth stages is finding the common good and the universal principles behind action. Now, a lot of times the argument that happens between parents and teens is that the parents are operating from this common good, universal principles idea about treating everybody fairly and making the world a better place. But the 15-year-old is very much operating from the approval of the peer group, morality. And so parents believe that their children are amoral when in fact they're just operating at a different level. And then finally, the last stage, the last bucket is that late adolescent phase, which is when you're supposed to be consolidating an identity. Up until now, you've been trying on different hats. And now you're trying to look at what it is that you really want to be able to do moving forward. You're also hopefully experiencing intimacy. Now, that doesn't necessarily mean sex. That just means closeness. You know what close relationships are like, and you are preparing to leave home, or at least that's on your radar. And so those are some common issues when I think about adolescence, and I try to divide up into those three different buckets.
What's the best way a loved one can support an older or younger teen as they face their worries and anxieties?
First thing to realize is managing our own expectations. Here's a way to describe it. Imagine you've got you got a dog, right? And it's a puppy, and it's cute, and it chews on everything, and you do all this work to train it so that it gets over puppyhood, and now it's a dog. I mean, it loves you, it wants to do what you say, and it's great. And then one day you come home, and not only is your dog not a dog anymore, but it's changed into a cat, and not any cat, just the snobbiest freaking cat you've ever met in your life. Like, it only talks to you when you got milk in your hand. It hisses at you for no freaking reason. I mean, it just suddenly becomes like this night and day thing. Now, I use that analogy a little tongue in cheek because a lot of the parents that I work with these teens, they haven't adjusted their expectations. They've gone from a dog to a cat, and they're ticked off about it. So one of the things that I have parents do as far as supporting teens is remember, you don't have to swing at the pitch. Your cat, because they used to be a dog, but now they're a cat. Your cat is going to hiss at you sometimes. Okay, you can't die on every hill. You can't swing at every pitch. And if you attempt to do that, then it's going to create a lot of brush fires that you're going to spend a lot of time fighting. So what I try to do with parents is I try to help them learn attuned communication. Now, most parents, of course, have jobs and they know how to communicate. Otherwise, they wouldn't have a job. But attuned communication is about timing. What happens for a lot of parents is they store up all these grievances. And then when the kid messes up, it's like the dam bursts and all the grievances come out. Hey, you haven't been doing this. You haven't been doing this. You haven't been doing this. And then the kid feels like kid who's got their hand caught in the cookie jar. There's a lot of hissing that happens at that point. So what I kind of share with parents is it's not what you're saying, it's when you're saying it. If the kid is at that point defensive, you want to teach when the relationship is good, which also means you can be direct. I mean, kids know when you're beating around the bush. So assuming that they're in a space where they can hear you, just be upfront and direct with them. And when you have those moments where you guys get into kind of like a tiff with each other, you can always reestablish closeness afterwards. I mentioned to parents that repair is more important than rupture. If you're going to be engaging with your kids, you're going to have moments of rupture, but it's up to you as the parent to look for those opportunities to repair and not expect the kid to initiate them. Because I think that's a lot of times what parents are waiting for. They're waiting for the kid to revert to a dog that'll come up to them and want to nuzzle them and want to lick their face and everything. And, that doesn't happen until they have their own dogs, unfortunately.
I love the analogy of the cat and the dog. What happens when you're a cat person? Does this analogy fall apart a little bit?
No, it still very much applies.
I guess cats are the strangest and meanest people you'll ever meet.
Well, they can be. I don't want to offend any cat listeners, though.
We love cats in my house.
Oh, good.
So what are other warning signs that you look for as you're working with teens? What else do you want to rule out?
Okay. So there's some general rule outs, and then we'll go back to our three buckets that we were talking about earlier. So our general rule outs is we want to rule out drug and alcohol use. We want to rule out abuse or trauma. We want to rule out sexual orientation stuff, especially if they come from a culture or environment where those kind of discussions are forbidden. We want to rule out interpersonal drama or bullying, and suicide and self-harm and psychosis. So remember before I said you want to be direct with adolescents, assuming that you're in a good space and you're not trying to teach when the relationship is bad, when the adolescent is hissing. When in doubt, just ask, hey, are you having any thoughts of suicide? Are you having any thoughts of hurting yourself? Have you ever struggled with drug or alcohol stuff? Be direct with them. Most adolescents see it a mile away when parents are like, hey, we had a cousin who struggled with being gay. Hey, I wonder if that's anything you ever know about. Just be upfront about it so that way they feel like you're meeting them at their level. Now, there are some specific concerns that you have going back to those three buckets I mentioned earlier. So let's go back to the early adolescent period. Again, this is the 11 to 13 range. So some problem signs to look out for, in addition to the things I just mentioned, is if they're consistently secretive about social activities, like they don't let you in at all as far as who their friends are and what they're doing. They're refusing to bathe or groom. It's not like just the stinky male adolescent thing, but they just never even think about it. And they're not even interested in having friends. They get along well with adults, but there's like no interest there. Those would be warning signs in that pre-adolescent, early adolescent phase. Now, in the second bucket, that middle adolescent, the 14 to 16 phase, some problem signs was if they have like indiscriminate sexuality. Like most kids are going to experiment with sex, but they are kind of indiscriminate about it, or they're unusually nervous about sex. So they go to one extreme or the other, and they don't feel any guilt when they do something wrong. I'm not just talking about those moments where they're defensive, but later there doesn't seem to be any remorse, and they have a very narrow range of interests in what they do and who they hang out with. And then finally, in our last bucket, which is the 17 and up strategy, these are some problem signs, is when they have no plans or interests. They have no plans for the future, and they don't seem to have any interests in talking about it either. Or they say they want to go to college or the military, but they're not doing anything to take steps in that direction. Or if they're like still arguing about those middle adolescent rules. I mean, by now, by 17 and up, some of those brush fires should have died out a little bit. But if they're still getting into this freedom, accountability brush fire, that might be a sign. And finally, if they don't have any interest even in dating or forming closer relationships, that may also be a sign. Of course, it could also be a sign that maybe there's something related to sexual orientation that needs to be looked at as well.
So just to be sure, I mean, it sounds like there's a lot of flags that we need to look out for that masquerade as anxiety. And how many of these, or how often are these things? I mean, they're very intertwined. So how do parents, or how do we counsel our parents when they're coming to us with these particular situations? What do we do to help reassure or help move them along a management path when they have a teenager that's not interested in friendships or is not bathing? What do we do in those situations?
Well, what I would do is I would first kind of talk to the adolescent alone and go through those questions that I mentioned before, and then get the adolescent's permission to kind of bring up some things to parents. Say, get an idea of what's okay and not okay to mention to parents. And then when you're talking to the parents alone, you can say, look, there does seem to be some worries here. I got some follow-up questions to see if any of these things are a concern. And then you can bring up some of those points that I mentioned based on the adolescent's age. Now, if the parent endorses some of those things, then what we can counsel our parents to do is we can talk to them about the attuned communication piece and talk about how closeness, the ability to interact with the kids in positive ways, is going to be a nice protective factor to help those kids deal with those things. We also probably want to encourage them to diversify. Now, what do I mean by that? Well, think of a 401k. What we don't want to do is put all of our retirement in one company, because if so, if it goes away, all of our savings goes away. So what we want to encourage kids to do, especially in that middle adolescent phase, is we want them to diversify their interests and their groups of peers. I'll tell you, the kids that have the best time in adolescence are the kids that have a variety of social groups that they're involved in. And they're not in the apex of any of them. The kids that are at the tippy top of the social hierarchy and the kids that want to be the queen bees and wannabes, as it was referred to years ago, they're miserable. I mean, because they're always trying to stay on top of the food hierarchy. Now, we don't want them at the very bottom either, where they're neglected or ignored. What we want is ideally kids that are in that happy middle area, where they have a lot of friends in different groups, And they also have a variety of different interests. That way, using my finance metaphor, if one stock, so to speak, goes belly up, they've got a diversified social portfolio that they can go to. The kids that take it the hardest is when they overly invest. They put all their eggs in one social basket. And then when that social basket struggles, it's like everything is taken away from them. We want to help them diversify, and we want to start it, especially during that middle adolescence phase.
Okay, I'm not exactly sure how to ask this question because I think it was partly discussed in what has just been mentioned, but it was about what factors seem to positively combat anxiety-based symptoms.
Yeah, exactly. That's what I was trying to move towards. Is it's about closeness, it's about diversification of interests and social groups. If we can do those things for kids, we can have a close relationship with them even when we go through those hissing moments. And if we can help them diversify their interests in social groups, assuming that they're not doing any of those big warning signs, they're going to go through some bumps. They're going to go through some turbulence, but the turbulence usually evens itself out.
This is a little bit, maybe a little bit off the path that we were going down, but how do you encourage children, especially as a mother of several young kids who've just been through, relative social isolation and a lot of their key social milestones were affected during COVID lockdown and things like that. I see a lot of kids in my own house and in my neighborhood that they're quite happy Netflix and chilling. Like they don't want to go out, but they're at the age where they should want to go out, I would think.
Yeah.
How to combat this kind of overall trend?
Yeah. Yeah. It makes you nostalgic for those times where we were worried about kids going out, driving and having sex, right? I mean, in a weird way, it kind of does, And so, COVID really affected kids psychologically moving forward. So I think one of the things, remember how before we were talking about being direct with kids, once you're in a good space with them to be able to say, look, I've got a concern because it seems like all of your eggs are in one basket called Netflix. And I'm getting a little bit concerned that becomes a habit for you. What are some ways that we can diversify this a little bit? Because I am concerned that if this lingers and moves on for you, it might kind of restrict your interests moving forward. And so having those direct conversations, and especially if they're the 14 and up range, you've got to do a lot of collaboration with them. I mean, if they're younger than that, maybe you can give them some edicts like, okay, only this much amount of time on Netflix. But once they're 14 and up, their autonomy has got to be respected. And so you've got to pull alongside them to help them to kind of see where some of this is going.
I think we've already said this in other ways, but how does anxiety affect a teen's social life beyond just I'm afraid to ask that person out on a date or how does it affect it?
Well, I think a lot of it comes down to their peer group. What I kind of warn parents about and kids about is the drama triangle. Now, the drama triangle works like this. Kid A, kid B, kid C are friends, right? Kid A is your patient, and C and B and C are their friends, and B and C have a falling out. And so A is like relaying messages between B and C. And that always ends in disaster for kid A, who is just trying to be helpful. So what I try to do is I try to help them realize that kind of this relaying messages type of thing between kids usually doesn't work. And so part of it is if kid B or kid C comes up to you, usually to talk crap about the other kid that they've had a falling out with, what is your job? Your job is to listen. It's to be nice about it. And it's to say, well, here's what I would do if I was you, and redirect them to go give messages for themselves so that way the kid A isn't kind of brought into this mess in this way that kind of increases the tension within them. Because otherwise you might just go to Netflix because Netflix doesn't ever accuse you of gaslighting. Netflix never accuses you of some of these things that kids get accused by. And so those are some things that I kind of have parents and providers kind of talk with kids about.
once you decide that anxiety is an issue, how do you intervene? And I want to insert something else into this.
Sure.
Because I have personally had maybe 2 episodes of anxiety in my life that I can really identify as anxiety. I'm not an anxious person, but I can remember specifically 2 episodes where I thought, what is going on? Am I going to die? This kind of a thing. What kind of anxiety symptoms do you see in these teenagers and adolescents? In other words, how do you identify that they are having anxiety, and how do they identify that they do? And then we would talk about how you intervene then.
Well, what I do is imagine you're in my office. I've got the teen, maybe the parent still in the room. I bring over my whiteboard and I said, look, anxiety is not your fault, but it is your job. And what does that mean? That means there are certain things that feed the anxiety. There are 4 main factors. So what I do is in the middle of my whiteboard, I put the word worry or anxiety. And what I do is I have 4 arrows pointing towards that word worry or anxiety. And I go through the following 4 factors. The first factor is body cues. People that have panic, they focus intensely on what their body is telling them. It's almost like they have a magnifying glass for any irregular heartbeat that they might be having. And unconsciously, what you do is when you focus a lot on these body signals, it can create a runaway train called panic attacks. So I described that factor, that first factor, a little bit for kids and teens. The second factor are our interpretations. I say, look, human beings, it's a blessing and a curse. We can go into what if land where we think about all the bad things that might be happening. But persons with anxiety, they make 2 fundamental errors. One, they exaggerate the likelihood of something bad happening. And 2, they exaggerate how bad it's going to be. So another piece of dealing with anxiety is calming the body, but also learning how to redirect the mind when anxiety is selling us on some of these exaggerations. The third factor is our behaviors, what we do when we're anxious. So if my body is freaking out and my mind or my thoughts are freaking out, it changes my behavior. Specifically, I do one of 2 things. I either avoid things that frighten me, I run away, or I try to control. If you've ever met a control freak, this is not somebody who is evil. This is somebody who is anxious. And they feel better if they tell people what to do and how to do it. And so I describe to people how, when the time is right, we'll help them in a gradual way either face fears or let go of what they're trying to control. And then the fourth and final factor is how they interact with other people. People with anxiety tend to either repress everything and hold it in until it all comes out, like in a word vomit. And then they say, oh gosh, I shouldn't have said anything. And then they hold everything in again, kind of like a teeter-totter. They go back and forth. And then they come to me thinking they have bipolar disorder. A lot of times they don't. What they have is they have an assertiveness problem. We need to find a nice, even balance of saying, you know what, I'm not okay. Here's my concern. What's yours? So if we can change the way we relate to our body, if we can change the descriptions we give our mind, if we can face fears and we can be assertive, even if the anxiety is partly related to temperament or the past or development, if we can change those 4 things, generally the anxiety becomes more manageable and we're able to move on to those developmental milestones that we talked about.
So when it comes to facing challenges and worries, I think it's important that we always test ourselves, but when is it appropriate and when is it not appropriate for these adolescents to face these challenges?
Well, as far as helping them face the challenges,
Yeah.
let's go full circle. Let's go back to my initial questions. A parent, a provider can sit down with the adolescent, normalize the fact that they're having worries and say, how much are these worries controlling you? And in what way do they do that? And how can I help you with that? Right? If the adolescent is saying that, more than 30% of the time, the worry controls them as opposed to them controlling the worry, then usually they can be a little bit more open to the idea of somebody helping them as long as it's done in a collaborative spirit. So it's about really, and this is what I say to adolescents all the time, it's really not about not ever having worry. It's more about how do you make sure that you're in the driver's seat so that it doesn't control you and it doesn't take over your life, because sometimes that can become a habit, and it can be a habit that can be difficult to break.
I feel like you've brought up a lot of really great points and a lot of things to look for. What is one thing, or maybe a short list of things that I can give to a patient? And I work predominantly with adults, not adolescents, but what can I do to start them on their journey to facing their anxiety and moving forward from the paralysis that is, what keeps them away from being their best self? What can I tell them in clinic?
Well, on day one, after you've asked those assessment questions that I mentioned before, what you can do, depending on how much time you have, is you can bring over your own whiteboard and you can kind of sketch out what are the 4 things that feed anxiety. Because at this point, it assumes that the person has endorsed the fact that sometimes their anxiety controls them. They don't control the anxiety, which we can normalize, and we can say, look, hey, I've been there with you. It's okay. We're all part of the club, right? And then after you bring in these 4 factors, you can say, which one do you want to begin with? That's the part of the story that I didn't get to, is after I bring over my whiteboard and I sketch out these 4 factors, I pause and I look at the adolescent and I say, which one of these seems to be driving your anxiety the most? And then based on which one they want to prioritize first, that's where I go. Because if they say, well, yeah, a lot of my body kind of like rebels against me, then I'm going to teach them breathing strategies. I'm going to teach them ways to relax themselves. If they notice their brain giving them a lot of these exaggerations, I might do some cognitive behavioral kind of work as far as helping them identify when their thoughts are kind of spinning out of control. So I think, again, it goes back to this collaboration thing. And I think that's important with anxiety, because remember, it's about control. And I want to empower them to have that feeling of control.
That's great stuff. Thank you.
Sure.
Dr. Johnson, did you have any other questions?
Well, I did, but I don't know that it is appropriate in this particular context. I just saw in his bio where he has extensive training in eye movement desensitization.
Yeah.
I read that and I thought, okay, what is that?
EMDR is what it's called. It's a therapeutic techniques that mainly is focused on trauma to help the person, or the adolescent for that matter, be able to disengage from the trauma in a healthy way so that they're not reliving it constantly. So that's the nutshell version of that, but we can talk more about that if that's something that people are interested in. EMDR, by the way, quick plug, I guess, is something that most of the clinicians I work with are trained in. I work at the counseling center, as was mentioned before. We've got about 15 different providers in offices, both in Centerville and Layton. If people are interested in doing referrals, obviously they can reach out to me at Bushman at counselingcenterut.com is my email address, or they can go on the website at counselingcenterut.com and they can provide a list of our providers and things like that. Most of us have been trained in EMDR, and that might be a good first step because I recognize there's only so much you can do within 15 minutes of being with somebody, and those might be some good resources to point people towards.
I don't want to condense the work of EMDR and its therapeutic benefits down into 1 or 2 sentences, but could you maybe give us a succinct definition of it? I mean, it's in the title that it's eye movement desensitization, but what does that mean? Does that mean that we close our eyes and imagine something? Are we looking?
Go through REM stage, a rapid eye movement when we're sleeping, right? And there's a lot we don't know, but what we do know about, what we think we know about REM, and the reason why our eyes go back and forth like that, is what we're doing is we're categorizing the day's events. And this is why if you deprive people of REM sleep, they don't learn as well. Well, people that have been through trauma, the trauma that they experience, we believe gets stuck in the limbic system of the brain. And so what we do is we have people bring up some traumatic memories that they get stuck in. And then what we do is we do something called bilateral stimulation, which means we have them follow our maybe some fingers in front of their eyes as they go left to right, right to left. And then we just kind of help them follow through the trauma as a way to help get a little bit of healthy distance from it, to decrease the intensity of the flashbacks. It sounds a little hokey, I recognize, but it has a really good empirical research basis behind it. It was originally developed to help PTSD vets returning from war, and it has about 20 to 30 years of research behind it. So it's only one example of a way that we can do trauma, but that's the best way I know to kind of condense the research down to something hopefully bite-sized.
And just to be sure, you're saying that a person is thinking through their traumatic memory while also moving their eyes left and right? Is that?
Yeah, but it's done in a very specific way that you have to get advanced training in. So it's not something that I think that you can just instruct people to do on their own, because you have to have a therapeutic relationship, and there's a very specific protocol for it.
Interesting stuff. Well, that actually brings me to a question I was wondering I could ask about. You have a book that you published a couple of years back on becoming okay. Yeah. Can you tell us a little bit more about that?
Sure. Yeah. It's called, Becoming Okay When You're Not Okay. It basically is an integration of Western and Eastern philosophy. Western is a lot of the psychological research, but Eastern is more about how do we use acceptance, including mindfulness strategies. According to the Buddha, there are two types of pain we experience. He called them the first and second darts of suffering. The first dart is the pain we get just from growing older, or people not treating us right, or having pain. Okay. It's just the pain life gives us. But the problem is, as human beings, is we inflict upon ourselves the second dart. And the second dart, to use the Buddhist term, is the dart of suffering. It's judging the first dart. I can't stand this. This is horrible. I don't like this. And when we get stuck in that second dart, that's when we get impulsive and we do things to shoot ourselves in the butt, essentially. And this is where we go and have extramarital affairs. This is where we go and get drunk. This is where we do all these things. Somebody's about to do something dumb when they say to themselves, I can't stand this, right? The more they say to themselves, I can't stand this, I can't stand this, I can't stand this, they're about to shoot themselves in the butt. Now, look, I've been there, but part of the Eastern philosophy is mindfulness, which is being able to accept or hold with gentleness the first dart of the pain that we all experience as human beings, while being able to let go of that second dart so we don't do all these impulses that, if we do them enough, eventually gets categorized in the DSM as a psychological disorder, right? About 80% of the diagnoses in the DSM are related to people feeling uncomfortable and then doing something impulsive with that discomfort habitually till it gets categorized into a particular category, right? And so it really was my attempt to kind of integrate Western and Eastern philosophies, because the irony is this, and it sounds stupid, but here's the irony. If you can be okay with not being okay, eventually you'll be okay. But if you're not okay with not being okay, you may not be okay because you're going to do something to shoot yourself in the butt that you're going to have to play cleanup on later. And so it's my way of trying to help us use acceptance so that we don't have to play cleanup later.
As a pain physician, I am constantly thinking about the first and second dart. I have different terminology for it. I call it the injury and then the suffering.
Yeah, there you go. You can use that. That's great.
Yeah, and so these things, pain is it's not a vital sign like your heart rate or your blood pressure.
Yeah.
It's something that is only possible because it's able to be subjectively measured by the person experiencing it. Yeah. And what I tell people is when they're unconscious, they can't have pain. And really the only way to have pain is for your brain to be on and working. But suffering is really pain in a nutshell, or chronic pain in a nutshell.
Yeah.
So I see a lot of crossover of what you were talking about and the suffering that I see every day. So thank you.
Sure.
And thank you for succinctly describing that.
Sure. If people are interested, my website at drbryanbushman.com has some more information. drbryanbushman.com if people are interested in that.
Perfect. And I see that you actually have quite a lot of resources on your website, handouts for adults and children. I know that we've kind of gone through most of what we wanted to talk about. Do you want to talk about anything that somebody can find on your website?
If people are interested, there are some exercises on there where you can get examples of mindfulness and being able to, how do you do mindfulness? So that way people have an opportunity to just kind of try out some things on their own. And they can read an excerpt of the book and find out if it's right for them.
I love it. And some of these, I like this, how to ignore minor childhood misbehaviors, dealing with sibling fighting, teaching other kids.
Yeah. I'll be putting on the website in probably the next 2 days. I'll be putting a series of talks that I gave about how to manage misbehaviors in elementary school students. If physicians are interested, they can direct parents to that. So that way parents can go and watch those videos for free to learn some behavior management strategies if that's something that people are interested in.
Wonderful. Yes. And I can see these are all free access. There's no paywall or anything.
Right.
Thank you. That's wonderful.
Sure.
Dr. Johnson, did you have anything else you wanted to ask?
No, thank you very much. I enjoyed this.
Yeah, thank you, Dr. Bushman. It's been a pleasure talking with you and learning a little bit from you today. Thank you so much.
Sure. Thank you so much.
The producers of this show were Clark Madsen, MD and MS, Teresa Puskedra, MPC, and the Ogden Surgical Medical Society Board of Directors. The Executive Director is Teresa Puskedra. Your hosts were Kristen Baca, MD, and Val Johnson, MD. Editing and sound design were by Owen Service. This is all supported by the Ogden Surgical Medical Society like you. Thank you.